Myofascial pain syndrome is a severe burden in modern musculoskeletal care. Patients with this condition account for up to 93% of pain management visits. This localized, referred pain originates from a specific source, the myofascial trigger point, a hyperirritable nodule trapped within a taut band of skeletal muscle. Historically, clinicians have diagnosed these trigger points using a set of clinical criteria originally proposed by physicians Travel and Simons. This traditional approach forces the physician to rely on a subjective collection of clinical signs. Chief among them is manual palpation, feeling the muscle by hand to locate the knot. The clinical problem with this standard is severe. Multiple comprehensive reviews have proven that manual palpation suffers from extremely poor inter-rater reliability and agreement. Compounding this unreliability is the fact that standard radiographic imaging, like an MRI, cannot detect this specific pathology. This diagnostic blindness directly handicaps the most common intervention, the standard, unguided trigger point injection. Relying entirely on a physician's subjective sensation of a taut band directly causes high rates of anatomical misplacement, explaining why so many patients experience a rapid recurrence of localized pain. This 2021 systematic review evaluates how diagnostic ultrasound provides objective morphological evidence of trigger points. We can see in this prisma diagram the screening of nearly 1,000 records, narrowing the field down to 11 eligible randomized controlled trials. The review notes that standard B-mode ultrasound provides the first crucial layer of visibility, revealing trigger points as distinct, hypoechoic, spherical, or elliptical shapes. Doppler ultrasound adds another layer of verification by measuring distinct vascular resistance, identifying characteristics like retrograde diastolic flow within the affected tissue. But elastography is the most promising modality within the review because it explicitly measures the physical stiffness of the tissue itself. Diagnostic ultrasound upgrades the clinical standard. Myofascial pain syndrome goes from a collection of subjective symptoms to a disease defined by a measurable physical biomarker. To understand exactly how this biomarker mapping works in practice, we look to a micro-level proof of concept, a 2019 randomized controlled trial conducted by Kang and colleagues. The researchers isolated the upper trapezius muscle and applied a specific diagnostic tool called shear wave elastography. Here is the physics. An ultrasound probe induces a mechanical shear wave into the soft tissue, tracking its propagation velocity. Faster waves indicate denser tissue, allowing the machine to quantify mechanical stiffness in kilopascals. In this baseline elastography, the solid blue map indicates a low stiffness of 75.3 kilopascals in healthy asymptomatic tissue. Contrast that with an active myofascial trigger point. We see a localized red and yellow hotspot, indicating a severe stiffness spike up to 175.3 kilopascals. The machine places a region of interest box over this extreme stiffness, locking in coordinates of the underlying pathology. This stiffness doesn't always present as a single point. It can manifest as an extended taut band, shown here as an elongated shape on the map. Shear wave elastography removes the guesswork. The physician is no longer hunting for a knot by feel. They have a precise visual target, verified by quantifiable mechanical resistance. The Kang trial was designed to answer one central question. Does seeing this target via elastography actually yield better clinical outcomes compared to a standard blind injection? The study enforced highly specific inclusion criteria, recruiting 41 patients aged 40 to 49 who had presented with a palpable, tender nodule in the trapezius for over 1 month. This flowchart details the randomization process. The 41 patients were split into 2 distinct treatment pathways, a trial group receiving ultrasound-guided injections and a control group receiving blind injections. The researchers established a strict control variable. Both groups received the exact same pharmacological intervention, a specific dose of 1% lidocaine diluted with saline. During the 4-week trial, patients were instructed to perform daily stretching, but were strictly forbidden from taking other analgesics or participating in additional physical therapies. Because the injected drug and the aftercare protocols were identical, any statistical divergence in patient recovery at the 4-week mark must be attributed entirely to the accuracy of the needle placement. The 4-week efficacy results evaluated both subjective pain severity and objective functional recovery. Looking at the primary outcome metric, the visual analog scale for pain, this chart illustrates the drop in daily pain severity. The blind injection cohort improved by 1.20 points, while the ultrasound-guided group dropped by 1.92 points. This confirms the ultrasound-guided group experienced a substantially deeper reduction in their daily pain compared to the blind cohort. Transitioning to functional outcome measures like the Neck Disability Index, the divide widens. The blind group showed a 5.85-point improvement, but the guided group nearly doubled that with an 11.14-point recovery. This functional superiority carried over to the Shoulder Pain and Disability Index. The guided group improved by 20.14 points, compared to just 9.70 points for the unguided group. Statistical analysis verified the mathematical significance of these gaps, confirming p-values of less than 0.05 across all three metrics. Accurately placing the needle inside the physical biomarker dictates the efficacy of the treatment. We can pivot back to the broader deep systematic review to contextualize these lidocaine results within the entire hierarchy of available interventions. While the King trial proved ultrasound-guided lidocaine is superior to blind lidocaine, the deep data reveals that local anesthetics might not be the optimal tool overall. This chart ranks the head-to-head comparisons of ultrasound-guided procedures, evaluating chemical injections against purely physical ones. Local anesthetic sits at the bottom tier. Moving up the tiers, ultrasound-guided dry needling and pulsed radiofrequency consistently outperformed local anesthetic injections across patient pain outcomes. Dry needling also generated better results than more complex regenerative therapies like platelet-rich plasma, though it fell slightly short of meniscalpal procedures. This clinical hierarchy tells us the primary mechanism of healing is not pharmacological numbing. It is the rigorous, localized mechanical disruption of the tissue itself. This brings us to the precise pathophysiology of myofascial pain syndrome. Localized trauma or repetitive strain triggers a cascade of inflammatory events deep within the muscle. Biochemical mediators like bradykinin and serotonin accumulate in the tissue. This accumulation causes severe capillary compression, which rapidly restricts blood flow and induces tissue ischemia. This ischemia locks the muscle fibers into a persistent sarcomere contracture. That microscopic physical knot is exactly what the shear-wave elastography detects. Look at this source imaging. Visual guidance allows the physician to drive the needle along this precise trajectory, terminating exactly within the dense red hotspot of the contracture. The needle requires millimeter-level accuracy to successfully break apart the contracted sarcomeres and restore local blood perfusion. Attempting to resolve a microscopic internal contracture based solely on surface palpation introduces an inherently unacceptable failure rate into the procedure. Integrating shear-wave elastography allows clinicians to objectively verify and precisely quantify myofascial pathology, eliminating diagnostic guesswork. Tracking the intervention in real time ensures the precise mechanical disruption required to break the ischemic pain cycle. The data on this is definitive. Eliminating anatomical misplacement guarantees statistically superior reductions in patient pain and long-term disability. In modern musculoskeletal care, the era of the blind trigger point injection is obsolete. Clinical efficacy requires visibility.